Dear Professor Richard Moth, co-chair of APMEN Surveillance and Response Working Groups, distinguished speakers, colleagues, and friends. Ladies and gentlemen, good afternoon in Laos and also in these regions, and good morning for some of you. Today, I'm very pleased to welcome you to another TechTalks webinar hosted by the Surveillance and Response Working Group, or in abbreviations SRWG. As many of you may be familiar with, the TechTalks webinar series is a flagship APMEN event to support knowledge exchange in key technical areas of interest between our 50 partners institutions and 21 national malaria control programs. This is among many activities led by each of the technical working groups to identify potential gaps where knowledge sharing may be leveraged to support capacity buildings for malaria elimination within our borders and across the regions. Since 2021, I have taken up chairing the Surveillance and Response Working Groups along with Professor Richard Moth from the Maidon Oxford Tropical Medicine Research Unit in Bangkok, in which the working groups is currently being hosted. The SRWG is a peer-led working groups, and in alignment with the spirit of our co-legions forums, we have continued to target the delivery of activities that our colleagues from both the national programs and partner institutions have jointly identified as a priority. In light of regional elimination goal of 2030s, challenge surrounding data qualities and its implications on the strength of our surveillance and response systems has emerged as a key topic of interest. Based on our discussion during the SRWG annual meetings last November, dear colleagues and friends, as we move towards eliminations, ensuring that our surveillance system is capable of capturing individual cases in a timely manner, this will be absolutely vital to detecting outbreaks, targeting responses, and preventing re-establishments of malaria in low to zero transmission settings, which we all don't want to see it happening. This will require addressing data quality challenges at various stages, from central down to the grassroots levels, from data collections in the field to data management processes at various health administrative levels. Technical solutions such as mobile applications have emerged recently to encourage the transition towards real-time data or near real-time monitoring of malaria cases to develop more impactful and timely response. But we still need to consider which applications that we have seen here today in many mobile phones, which application is simple enough to handle and widely accepted by users. And we should not forget our users who are working at the grassroots level, who may not have all the knowledge that we are sitting here around. And recognition that quality of data is required to guide program plannings, manage resources, monitor program functionality, and leverage financial and technical support has also been made. As such, today's webinar seeks to further highlight the importance of good quality of data to promoting a functional and effective surveillance and response systems, and introduce some tools and best practice that can help us to achieve this. For this, I would like to welcome Dr. Yasume Ye, Vice President of Malaria Surveillance and Research Unit at ICF and the Technical Director of Malaria Surveillance at USAID, to present about the malaria routine data quality assessment tools. And also share example of where country may be used to monitor and improve the quality of the data and surveillance systems. Additionally, we have speakers from two national programs. The first one is Dr. Putnalong Vilai. He's the head of the epidemiology sections at the Center of Malariology, Parasitology and Entomology here in Lao PDR. And Dr. Musikia Raman, he's an epidemiologist at the National Malaria Elimination Program in Bangladesh, to speak about some of the initiatives their respective programs have undertaken to improve the quality of the surveillance data. Following the presentations, we will have a question and answer sessions, during which I also highly encourage my colleagues and friends across national program and partner institutions to share your best experience as well. Without further ado, I would like to thank all of you distinguished speakers and my fellow colleagues, especially my dear friends here, Professor Richard Moore and his assistants who are at the background, for coming together and prepare all the necessary process that we can coming together 2 days to champion the network's core value of reciprocities. I'm very confident that we will engage in fruitful discussions and continue to inspire one another in our joint mission to eliminate malaria across the Asia Pacific by 2030. By saying that, I would like to express my sincere thanks to all of you for your active participation and all of the preparation that happened as VRG have prepared. So thank you very much. I hand over to my co-chair, Professor Richard Moore. Thank you.
Thank you, Dr. Atansai, for your opening remarks. And hello, everybody. Just before we begin, I'd just like to let you know about the mechanics for this webinar. So audio and video attendees will be disabled, so we won't be able to hear anyone except the speakers and the moderators. But you're encouraged to comment in the chat box, and you can submit questions in the Q&A box, and then there'll be a chance to vote on those questions. So if you look down, the questions that have been entered, if you like the question, if you click on the vote, then the ones with the most votes will try and get answered in the last 15 minutes. So we will hold all questions till the end, and hopefully we'll have about 15 minutes for responses from the speakers. So hopefully that's clear. We will move on to the first presentation. So Dr. Yasume Ye, who's already been introduced by Dr. Atansai. Dr. Yasume.
Thank you, Richard, and good afternoon, everyone. And thank you, Dr. Ratanasa. And good afternoon, all the panelists. And also good afternoon, all the participants. So it's a pleasure for me to join this webinar and share with you our experience, mostly in high burden setting. So this is a tool that we have developed. The development process started in 2018. I'm just moving my slide. So can you see my screen, please? Can you see my screen?
Yeah, we can see it.
Okay,
Yes,
thank you. Yeah. So the development of this tool called Malaria Routine Data Quality Assessment started in 2019 under the MEASURE Evaluation Project. So the MEASURE Evaluation Project is the project funded by USAID, led by the University of North Carolina with other partners, including ICF, my own institution. So my presentation, we cover 6 points. I'll give a quick background on the context, give an overview of the tool, and then discuss the implementation process. I'll give some example of use of the tool. I won't share any country-specific result yet because these have not yet been discussed with the country, but I'll give you an example of how the result look like. And then I will also share with you an innovation process as a way of improving the use of the tool. We are moving toward a mobile application. And then end with a few highlights on some of the potential limitations and how they can be overcome down the line. So as a context, you may all be familiar with the WHO data quality review tool, which was developed in collaboration with the MEASURE Evaluation Project. It includes a supervision checklist. It was a great tool, or it is a great tool because it's still being used, but unfortunately, it's a broader tool which cover all the diseases. So to the extent that when you want to look at specific disease, you have only limited number of indicator and data element that you can look at. The malaria community was interested in seeing more of the malaria indicator into this tool, but adding them will increase the tool and take more time during the assessment process. So we have decided to develop a tool which specifically focuses on malaria. That will include all the key indicator and data element that the National Malaria Control Program is interested in. And they match with the recommended key indicator from WHO, which is in the surveillance manual. So this tool was developed on Excel, and it's right now being used on the MEASURE Malaria countries, which I will speak to later down. So far, this is restricted to the country being supported by the project, but they are interested in expanding it to other PMI supported or PMI partners country in the Africa region. Now, moving to the structure of the tool. The tool, as previously mentioned, is with several tabs. The first tab is the cover page. The second tab is the instruction, where you have all the instruction, description of a tool and how to use the tool. And then the third one provides, that's where you input the information of the facilities. You first have to select the number of facilities that you want to look at. And then for each facility, you provide the names and any other information which is related to the facility. And then you move down to the fourth tab, which gives you the opportunity to define the number of indicator you want to look at, and then select the specific indicator and data element. And then now you move to the facility tab. That's when you start now looking at the data, looking at the 5 components of the data quality which you're looking at. And once you have all this information entered, then you can visualize on the dashboards where you see the outputs of how your data quality looks like. And then 7, you have a summary tab, which will provide you summary comments in each of the indicators that you have looked at throughout. And more importantly, interesting is the number 8 tab, which gives you a framework for you to define action which you're going to use to improve or address some of the data quality issue that you have seen. And last but not the least, is that once you have all the information entered, you got your initial analysis and output you can see to take action. If you want to conduct further analysis, maybe more advanced analysis looking at cross health facility, cross region and so on, you have an opportunity to export this information into a different statistical package where you can perform an analysis, more advanced analysis. So that's how the tool is structured. I'm going to give you a few screenshots as I refer to the initial page, the cover page. That's how the cover page looked like. The next page will be the instruction page, the instruction tab, which you can see here. So that's the screen on your right. And then when you go down the screen, the bottom right, that gives you the screen where you can enter all the information. You move to the next up left, that's the screen where you enter all the indicators. You first have to define the number of indicators you want to look at, and then you can define a specific indicator. The reason why we have given opportunity to design the tool to specify or to define specific indicator, we felt like there are a number of indicators. You will see the indicator that we have included in the tool. There are many. So we felt decisions should be made based on the issue that you're seeing on specific indicator. So when you go to the health facility, you don't look at all the indicators because that might take time, and you might not be able to zoom into the specific indicator with issue. So your preliminary analysis of what the data you have maybe from your DHIS2 will give you signal, or other supervision, visit and feedback, give you signal on some of the indicators which are really having issue. So you can specify them and focus on them during your visit. And the screen down gives you now the framework where you enter all the different information and do your assessment. Once you're done, then you move to the next tab, which will provide you the outputs and show some of the results of how your data quality look like in the facility and across several facilities. The tab on the bottom we give you all the detailed description, because for some indicator you're giving additional comments which are more text. You can view them and see some of the comments, look at the reason for specific issue with any specific data quality issue. All the description can come down there, and that screen will allow you to visualize some of those comments. And then the screen I was referring to, which I said is the most important, is not about really assessing what your data quality looks like. It's more of really what do you do once you have identified the issue. So here there is a template which gives you the different steps and how you can define a data quality improvement plan. So that's how the tool is structured. Now, what are the different metrics involved in this tool? We're looking at completeness, we're looking at data accuracy, we're cross-checking between different registers to make sure that there is a match, and then we're looking at also the consistency check. But we are also looking at the system, because any issue we're seeing with completeness, accuracy, and consistency, this system is being structured or how well this system is being supported. So in terms of a completeness, we're looking at 3 key indicators. The first thing is really the report submitted. So we're looking at here the monthly summary report, are they being submitted on time? So you're looking at the number of facilities which are expected to submit the monthly summary report, are they submitted? The second one, we're looking at the completeness of the data elements. So we review the register to look at individual data element and see whether they are missing information on specific indicator. same thing we do by looking at the monthly report as well, and see whether some cells are supposed to be filled, but they are not filled. So we look at the proportion. That's a basic indicator of what the data quality issue is. The second thing is reporting accuracy. As you know, there's a process of reporting summarizing information from the source register to the monthly summary form. So we verify these two information and see whether they match. From that, the monthly summary form information is reported into the DHIS2. Most of the facilities we are looking at are not reporting directly into the DHIS2, but they're reporting to monthly summary form, which is now consolidated at the district level and transferred into DHIS2. So we do a cross comparison to look at what we call the verification ratio, which should be 1 if they all match. And then we move on and look at, compares different registers. We take the OPD register and we can compare the number of cases that we're seeing, for example, on the OPD, in the OPD register, and what we are seeing from maybe the lab register. If you're looking at the number of positive RDT reported cases, we look at whether in a register, lab register, there is a match or mismatch. Now the consistency check. So what we do on the consistency check, we do actually an average. So you do expect that maybe from month to month, unless with a major issue, you don't expect any huge variation in number of cases. So we want to see if the cases that you're seeing this month are sort of slightly correlated with the number you're seeing the previous month. If you have a huge jump in cases, it could be a red flag. Either on data quality issue or some specific events happening that you have increased on specific cases. As far as the system is concerned, what we look at the adequacy of the system. And one of the key things is the availability of the tools, because the tool is very fundamental. Whether the tools are there, whether there is a regular supervision, whether there's a regular look at the data which is being produced at the facility level. And all these are key elements which will help streamline the system. Now, moving into to the indicator, we have 6 groups of indicators. We're looking at prevention, testing, cases, and treatment, commodity, and malaria death. So altogether, we have about 37 indicators. As you see, they're really a large number of indicators, and you have them listed here. So this indicator can be adjusted based on the country's context. If you think that the age aggregation is not appropriate for the country, they can be adjusted to specific age group that you're looking at. So once the district or the district team or the National Malaria Control Program team or the supervision team meet, they look at all the indicators and look at previous probably assessment or previous supervision and see whether the specific indicator which might have issues, they can select this indicator and focus on. So you have a list and pick up a few indicators which you can focus on. Now the process. So this tool was designed to be rolled into a routine supervision, supportive supervision. Or if you have specific issue that you really want to catch, you can also perform a standalone assessment. But because of issue of cost, you want to integrate it into an existing activity and make sure that during the routine supportive supervision, that data quality aspect is also looked at. It's a tool which is given to the National Malaria Control Program. So the National Malaria Control Program team will select the region and district where they want to focus. And most, as I've said initially, the selection criteria is based on issue that a region with specific issue or health facility with specific issue or district with specific issue. They focus on that. If you have enough funding, you can cover randomly so many health facility, but it's already advised to focus on the facility with issues so you can catch them and get them addressed as soon as possible. So during the routine supervision visit, as you're looking at case management, practice, and all other commodity, you also focus on the data quality component using this tool. And once you're done, you can preliminarily look at the results by facility, or later on at the district level, look across facility, and then export the data for further analysis if you want to do so. So as example, in country where we have already implemented that, as I mentioned, we cover about 10 countries under the project, all in PMI partners country, and all high burden malaria setting. Cameroon, Cote d'Ivoire, DRC, Liberia, Madagascar, and Mali are the countries which have implemented. The remaining countries are in the process of doing so. So as you can see, the implementation process started slowly as a test of the tool in 2020 for some of them, and then other will be joining this year. So we have not implemented that many health facility because we are restricting on really health facility with issue, as you say, by country. The number of facility cover are different. But what we have here, we do a first round for country which have been first implemented first round, and then there is a follow-up around which is implemented later down the line. Now, in some cases, the first round health facility will be different from the second round health facility. So if you choose that approach, which is fine because you're mostly really focusing on issue which you want to address, then you might have an issue of looking at trends. But you could decide to fix certain number of facilities which you want to look at, each round, but then vary other facility based on specific criteria and data quality issue criteria which you will have defined. But this is really totally up to the user, so the malaria program to decide on. Now, in terms of output, what comes out of this system, as I already mentioned, when you look at completeness, as you can see, the first thing is really reporting completeness, looking at the number of monthly summary forms submitted out of the expected forms. So you look at, then you can have the proportion of facility who reported or submitted the monthly summary form. And then you move into the next one where you're looking at data elements specific and look at the completeness out of all the different data elements, specific data element you've looked at, how many of them have data completeness issue, whether you have some missing information reported there. So this second graph will allow you to see this information. Now you move specifically and looking at data missing. You're looking at all the different facility. On this graph, what you see on the left are all the facilities. And then for each facility, how many data elements that you look at have a missing information or missing data. And that gives you now the proportion of missing information in this facility based on all the different data elements that you have looked at. Once you have done that, you can look at the data accuracy. The data accuracy is the verification ratio. In blue here, what you have, you verify the monthly summary form with the source document, which is the register. And ideally, it should be 1, the verification ratio, because what you see in the register is exactly what you have in the monthly summary form. So that's, if they match, you will have a ratio of verification ratio of 1. If they don't match, it's either up or lower. So that's an indication. The red one is you still use the source information which you have and check what is in your DHS tool. If they match, you will have a ratio of 1. If they don't, you will have it up or below 1. Once you've done that, then you can look at the reason, because you ask, when you see some discrepancy, you ask, what's the potential reason of this discrepancy? And then you can see the justification of why do we have this discrepancy. So this graph on your right side shows you how some of the reason that explain the discrepancy that you're seeing between the source documents and the summary form or the DHIS2. The next output is data consistency. So what you're looking at, you look at what has been reported maybe over the year, and you're looking at the value that you're seeing against that value. So ideally, you don't expect any major difference unless there are reasons for that difference. So it's a good indication for outlier. So basically you're looking for outlier and try to explain whether there's a good justification of this outlier or it is an issue with the data quality. So that's what this graph will tell you. So you sort of have some uncertainty boundary within which you're okay, but if you're outside this uncertainty boundary, which you can see with a dotted line here, then you should try to understand why do we have this discrepancy? Is there any specific reason for this discrepancy, or it's just a reporting error? And then, as I refer initially to the system assessment, that's where you're looking at whether all your pieces are the production and reporting of quality data. So one of the things that you're looking at here is this spider diagram looking at several components. So you have first on the right, you're looking at the reporting form, because that's really one of the key driver of data quality. Once you don't have all the reporting form in place, the likelihood of having data quality issue is very, very, very high. So you look at all these different components and see whether all the facility have all these different elements. And then you have the regular data review, because as a process of looking at regular data, it's also help adjust some of the issue that you are seeing as far as data quality is concerned. So you look at whether some of these facilities are going through this process or not. So having implemented this tool, it has really helped improve the data quality, because we have a process of really monitoring this and making sure that any issue which we see are addressed. And as a project, we work closely with the National Malaria Control Program. So what we have seen, and there are a number of reports which we are in the process of producing it and can be shared down the line. As I initially mentioned, some of the results of the improvement have not yet been clear by country, so I'm not able to share it with you, but very soon we should be able as a project to share it. And you can see the effects of using this tool on the improvement of data quality. So the Excel spreadsheet that is used, normally it's within a computer which is taken to the facility, and all the information, or tablet, all the information that are being entered. So there's still, it creates a bit of restriction. So we felt like maybe developing a mobile application will help further increase the use and facilitate the use at all levels of your healthcare system. At the facility level, you want to look at what is the facility. But when you move to the district and the national level, you want to be able also to see all the data quality indicators across region, across district, across health facility. So we're in the process of developing an application, a mobile application, which is already well advanced. This is being developed by one of our partners of the project, GSI. So the advantage of the application is that it's going to be an application which you can download in any standalone device, but then the information that you're pulling up is connected to the DHIS2 directly. The spreadsheet that we have so far is not directly connected to DHIS2, although now we're in the process of doing that. So you have to upload the information before you go, which creates some challenge. It will be directly linked to DHIS2, and all the information will be directly pulled out once you select the facility that you're planning to visit. And this is some of the initial configuration that we the screen of the mobile application, which is being in process. As you will see, it's basically sort of replicate what you see in the Excel spreadsheet. The only difference here is in the mobile application, which can be used wherever you go and have a good link to the DHIS2 data. So this is an example of screen of a data entry. Again, this is exactly the same screen that you have in the Excel spreadsheet. So quick example of a screen here. I won't spend so much time in the interest of time, just to give you an example of what they are. And this is in the process and the output. And you can see also on the left here, we also have the data quality improvement plan, which we think is really very, very fundamental. And I think it's the most important piece of this tool, which if well used, will definitely help improve the quality of the data. Now, although the tool is very easy to use, and most national malaria control program we have engaged with are really very pleased with how simple the tool is, and they have already taken ownership of the tool. So you don't need any external support. It takes just maybe one day or maybe half a day orientation of the tool and the process for the National Malaria Control Program to be comfortable with. And the supervision team can easily use it without any support. The support will be needed maybe at the additional analysis phase. If there are needs to perform advanced analysis, then the information can be extracted in the different statistical package for this advanced analysis, and maybe additional support might be needed there. But otherwise, the process of manipulating the tool and using it at the facility level is really very simple. However, one of the challenges that we're facing is the link to the DHIS2. As I mentioned, it's a standalone tool and information is uploaded before you go, but there is no direct link to the DHIS2, which now some countries are working to resolve. And with a mobile application, we will be able to address that issue. The second point, we're in a context here of this webinar looking at elimination. This is not designed for elimination. You can look at most of the indicator. We're really focusing on an indicator, which is the burden reduction setting. However, it's flexible and can be adapted to specific indicator you're interested in. We may have trick here and there and maybe look at a bit the output, but this is something which can easily be adapted. And as already mentioned, if you want to do further analysis and looking at some of the reason, the factor affecting the improvement or the change of the data quality, you have to extract it into a statistical package. There are thoughts, we're still thinking through whether we can design a module which can also perform some of the basic, I would say, advanced regression into the same tool. But this is still in a thought process. So on this, I just want to say thank you to the team which actually helped develop this. We work this closely really with GSI, and David Boone is actually the person who did all the programming behind the Excel. So big thank to him and my other colleague, Michael Pola, but also in the thought process and design process from the beginning, PMI team was involved. And here I'm saying thank you to acknowledge Leah Fleury. So there's a typo on her name there. So on this note, I will end by saying thank you to USAID for funding this project and this initiative. Thank you.
Thank you, Dr. Yazame. Just a reminder to the participants to put your questions in the Q&A box and to vote on the questions that you'd like to be asked at the end after the speakers have finished. So our next speaker is Dr. Putnalong Bile from the Center for Malaria Parasitology and Entomology in Lao. Dr. Bile, would you like to share your screen and start?
So dear Chair and Co-Chair, good afternoon everyone. I am Punalong Vilai, the based on Malaria Control Program in Laos. So today I would like to an experience on surveillance data quality for Laos. So on this presentation have 4 points. First is the implementations of the elimination surveillance. Second is the capacity building and decentralization for the staff. The third is the leadership and the partnership for elimination. And the final is the challenge of the program. For an implementation,
Dr. Pila, we can't see your slides in full screen at the moment.
You don't see the screen? Excuse me, you don't see the...
you can see the outline slide, but it's not full screen, it's the PowerPoint.
So here is already full screen. May I share it again? Sorry.
No problem.
Is full screen?
No, if you're using 2 screens, it's probably the other screen.
No. So if you don't mind, can you show the screen on your side?
Yeah, so we'll share from this end.
Okay, thank you.
Thank you.
Just give me 1 second. I'll just share the screen for you, Dr. Punalong.
Thank you.
All right, you can let me know when to move on to the next slide whenever you're ready.
Okay. So good afternoon, everyone. So today, I am Punalong. I would like to share about the experience of the on surveillance data quality from Laos. Next. So on the presentation, have 4 points. First is the implementation of the elimination surveillance. Second is the capacity building and decentralization for the staff. The third is the leadership and the partnership. And the last is the challenge. Next. So in order to implementation for the surveillance in eliminations area, so we rely on the guideline for elimination surveillance and response that improved in 2020. So we follow the 137 principle that to report the case in day 1, then to do the case investigation. So we do that in within day 3. If they have indigenous case, so the local staff will do the foresight investigation and respond within day 7. So next. In order to ensure that the information in for the surveillance that will be moved. So we do have train for the staff in elimination area for how to do the create notification and also case the classification and also the response for the foresight. So we do train for the 17 provinces as well as in the 125 districts, including the health staff in health center. So this we use the several fund from the Global Fund, WHO, and PMI as well. And the other thing is we also training on using standard that also we call that DHA2 to use and analyze for the data using and SL for the verify the data as well. Next. So in Laos, we have the Malaria network. According to this chart, so in each level have to verify and clean the data from each level. For example, in PAM, that means provincial levels have to check and verify the data from hospital, military hospital as well. So then in the same lines, then in DAM or district level, they do have to check the data from hospital, district hospital and military in this level. This also include the data from not yet. So this also include the data from PPM in this district area. Also in each level, they do have the investigation if they have case occur in the that level. Recently, so we emphasize for health center together with the village health worker to do the investigation. Moreover, for verify the data in every quarters, they do have plan for do supervision for verify the data in each level. They use supervision from checklist to do data verification, about to check about data between paper form and electronic data file. Next. So for the leadership and the partnership, that is very important. Seeing the Prime Ministers have signed on the innovation agreements that the government have a commitment for moving malaria elimination in the country. In addition, the malaria work, innovation malaria works that lead by the Department of the Communicable Disease MOH that push the malaria disease become a national notifiable disease in 2019. Meanwhile, Department of the Planning and Cooperation that improve the health information system or DSA2, as well as then this information system in Laos also include the malaria's data. For the partnership, this is the very crucial for Lao as well. They have many partners to support, such as WHO, SHI, PSI, and others, to develop the principal guideline for elimination, as well as the development of the surveillance data system, such as the DHA2. And they also support the technical staff and in local level. As well as the we have the financial support from the donor to do the implementation for the elimination works. For the access to the malaria data, so then the partners can access to the data platform as well. Next. So this graph shows an indicator for 2021. So for the case notification within 1 day and investigation within 3 days, these indicators is slightly achieved really well. So you can see it in this the percentage of the achievement about 87% and 86% respectively. However, for the foresight investigation and response, still need to improve with the result that is 8%. Next. So for the challenge, according to the results, the biggest challenge is the foresight response, because we had a difficulty on seasonal access and district capacity. The other thing is the malaria elimination works take time to build a subnational capacity, as well as the other is the resource ability in provincial level, district level, as well as malaria staff not serve only malaria works, but also serve for dengue, parasitic disease control, as well as the vaccination campaign and also the COVID response. So then the fourth point is the ability of the BMW are limited. So in this point, they require to have the refresh training in every year. So next. So thank you so much. It's over.
Thank you very much, Dr. Vilai, for your presentation. We'll move straight on to the next speaker, who is Dr. Muzaffer Rahman from the National Malaria Elimination Program in Bangladesh.
So, I am audible? Hello?
Yes, loud and clear on your slides.
My screen is shared is okay?
It is, it looks fine. Thank you.
So, thank you, APMEN Secretariat, and I am welcoming with due respect to Honorable Chair of this session, the Director General, and of course, the co-chair of this session, Professor Richard Modi. Today's I will give a snapshot on surveillance data quality, best practices or experiences sharing from National Malaria Elimination Program, Bangladesh. I am Dr. M.D. Moshikur Rahman. I am epidemiologist of National Malaria Program. So far, the today's topics is data quality in malaria elimination. And we as an organization understand data quality is the degree of nearness of data to the truth. And malaria elimination, which is also a high degree precision of data, high degree specification of data. So I feel today's topics is very much pertinent from Bangladesh perspective as well as Southeast Asia regional malaria perspective. And I want to provide the information in the light of this presentation outline. First outline, number one, I would share the uniqueness of data management system of National Malaria Elimination Program. Secondly, I want to share the malaria information system data flow. Thirdly, I want to share the data quality assessment of National Malaria Elimination Program. And fourthly, I want to share our innovation, new innovation, the geospatial dashboard or malaria API tracker, which we have built and carried out in practice. And last of all, the lesson learned we have. Regarding uniqueness of data management system of NMEP, firstly, I want to share that we have a comprehensive and costed national monitoring and evaluation plan. We have in this national monitoring and evaluation plan, there is a description of a composite monitoring evaluation framework that is from input, process, outcome, output, outcome, and up to impact level. And the details of indicators of this M&E plan, in this M&E plan, which the indicators have clear definition of denominator, clear definition of numerator, clear definition of specification of source of this document. And both aggregated and individual data are collected in this data management system. And for data collection tool, we have a unique data collection tool, Excel-based, online-based data collection tool, which has many dimensions: age segregation, sex segregation, provider segregation, species segregation, and it is a self auto that if there is a variation in numbers, there are lots of options which will signal that it's wrong or right. So in terms of uniqueness, we have a unique data collection Excel-based tool. Data collected from both government, non-government organization, and also from private sector in some limit. I am continuing my previous slide that the uniqueness of data management system of National Malaria Elimination Program. The data collected both in hard copy from field level as well as from electronic source. Our national monitoring and evaluation plan include routine data quality assessment or adequate tool, which my first panelists have very well defined and well described. And this routine data quality assessment tool includes regular feedback mechanism, and we do sample in each quarter, and throughout we have complete our all service delivery point this data quality assessment at in one or two indicator throughout the year. And throughout the year, we have completed the whole service delivery point of our routine data quality assessment. There are strict time frames is set out in our reporting system, and it is mandatory. No ways of deviation. Also, our data collection system, now we are having real-time data through SMS and through also our NGO use a Kobo Collect tool. And we have started GIS mapping in piloted some sub-district. We are piloting GIS mapping in some piloted sub-district at village level. And finally, I want to share our new innovation with support from MORU and technical support from MORU, the visual geospatial dashboard, and we called it Malaria API tracker, is being developed and starting our practice, which is a very management tool, and the management can see the progress. I will share detail in my follow-up slide. And this is our data data flow system of data flow. You know, Bangladesh, our lowest administrative unit is ward, then district, and then national. And here, this flow chart is self-explanatory. It gives you a self-explanation that this is the flow, both from GOB and both from government of Bangladesh and from national non-government organization, BRAC consortium. You can see, and each stage there is sharing, there is checking, and there is ultimately up to directorate level and up to BRAC headquarter level. And now it is now some area we collect monthly, and some area in elimination targeted districts we are collecting real-time data. And for the sake of time, I want to have permission. I am a bit speeding the presentation for the sake of time. So if time limitation, please co-chair or the please signal me that time limitation. So data quality assessment of NMEP. Our data quality assessment system consists of different components. Logical cross-check of data, we do it by using that Excel-based tool. Supportive supervision visit by surveillance medical officer, National Malaria Elimination Program monitoring evaluation person, and also from MIS section, epidemiology section, also from management, and similar supportive supervision visit, which has a supervision checklist on this data quality assessment, completeness, correctness, and these timeliness, all the dimension of data quality have our supportive supervision checklist have this. There is a section of checklist for supportive supervision for data quality cross-checking. And sometimes and it is routine that on-site data verification have been organized related to field visit, service delivery points. And for LLIN, we identified 10 beneficiary, and we physically go to their house, whether they have received and for this, thus we confirm or we check the authentication or validation of our LLIN providing report. And we also review training needs, and we have now we developed a built-in check in a malaria module of DHS2 based MIS, and it also validate our and cross-check our validity. Besides the following activities, we also have support regarding data quality by monthly meetings at Upazila level, district level, quarterly or annual meetings at central level, and also we have a routine meeting with surveillance medical officer bi-monthly at our central level. So at that point, we share the feedback. We share the feedback on data quality and make some arrangement for correction by the led by surveillance medical officer. And also joint monitoring visit been organized involving government, involving non-government organization personnel back, and also WHO personnel sometimes with us. And also there are some, we have a exercise on data quality assessment broadly, not only for malaria, but it was done in 2018 to 2019 by the Global Fund and by the National Institute of Nipur. Nipur have done that a massive portion of malaria and tuberculosis and also maternal health EPI. This exercise was done by the Global Fund with the partnership of Nipur, a national organization of health ministry, to deliver demographic and other survey. So that had also been done. That was also supported to our data quality in elimination setting. And also 3 to 4 years, there is a epidemiological EPI analysis, done by external consultant, and also a joint monitoring mission in every 3 years. This also provides some feedback to identify some flaws or in terms of data quality in National Malaria Elimination Program, Bangladesh. And here, this is the illustration. You can see how API tracker is now, how our all system is converging to API malaria API tracker, and which for tracking the trends of malaria. Here you can see our national our Excel-based malaria MEASURE system. From here, some data here, all the data is now shifting to DSS2 and also to the API tracker directly from this Excel-based national MEASURE system. Then BRAC also collect data from COBO toolbox, and they also infuse data to this malaria API tracker, and also our case investigation data directly enter into this tracking the trends, and also this monitoring platform of malaria API tracker. These 3 segments, DSS2 also will infuse data to this tracking the trends or malaria API tracker platform. And here you can see this API tracker will form a interactive dashboard with charts, graphs, and with geospatial map, where we can identify the heat map, where we can identify many information. I will share later on. And here you can see now our malaria API tracker. First, we can have annual parasite incidence map. Now you can see the geospatial map. We can segregate PF map, BV map, mixed map, and also API, our annual parasite incidence. Bednet coverage map, you can see there we can draw the coverage map in geospatial mapping. We can also produce malaria vector map, as you can see here, and we can also geospatially we can plot the health facility and health worker distribution map. And another utilization of this malaria tracker which is very much pertinent in data quality for malaria elimination. The charts, graphs on different indicators. And you can see, we can here draw a line graph, here the malaria case at Upazila level, yearly malaria case and death at Upazila level, bar chart, column chart, and age group. We can produce some pie chart, age segregation group and gender-wise bar chart, and also species-wise chart, also yearly malaria case versus severe malaria, case fatality rate, malaria test versus case and case positivity rate at Upazila level. And finally, by engaging with this robust data management system, it is mandatory that a robust data management system is necessary to maintain the consistency, to maintain the integrity, to maintain the value of elimination for data quality in elimination setting. And by engaging with this robust process, we have some lesson learned. I can show this lesson learned by simulating it with some graphical art by a talented person from International Federation of Red Crescent, MEASURE Guideline, a published document, free document. First of all, you can see often we face challenge that the data collection team, sometimes there is a building block between data collection team or M&E team with program team. Program team, if anything do to involve the data collection team, they like say, oh, I am too busy to collecting monitoring data. But our lesson learned and recommendation is, don't let M&E burden the very programming. It is supposed to serve the program. Data quality, data is needed for program, and there should not be any building block between M&E data collection team versus project program activator. And
Dr. Rahman, just so we got time for Q&A, is it all right to stop your talk just there?
Okay. And
Great.
that's for time sake, and that's for my all. I am almost almost I have completed my section. Thank you, Richard.
Great, thanks for your fantastic talk. It was really good. So we're planning to carry on for another 10 minutes or so. I hope that's okay with the speakers. And we're going to take some questions from the Q&A. So can I ask the speakers to switch on their cameras? I'll do the same. And there's been some very lively Q&A going on with some voting up and down. And we've got some questions that have got a few votes from different people. So I'm just going to switch and we'll read some of them out and see if we can have a go at answering them. So for the speakers, if you can see. For Dr. Yazamit, the first question from Jenny Kerrison, that's at 1:31 p.m. It says, thank you for sharing your work, very important. Was the tool used in locations in malaria control or elimination? What was their API? Were private sectors engaged in use of the tool? And is the tool linked to the WHO Malaria Elimination Assessment tool? So a few questions in there.
Yes, Avi, thank you. And that's a very interesting question. And then that's what I mentioned during my talk, is that the tool has been defined for high burden settings. So it has not yet been used in malaria elimination settings. So if you look at most of the indicators, they're really defined for high burden. However, because the indicator can be adjusted and maybe the output will also be adjusted based on specific needs. So we have not yet tested the tool in elimination setting. So as far as private sector is concerned, yes, the tool is used in the public sector, but it can be adapted because it's all about putting the characteristic of the facility that you want to visit into the system, and all other indicators will be the same. because private sector for most country a report based on the tool which is used in the public sector. They don't have any specific tool or register they have to report to, which is different from the public sector. It's the same. So when they report. So if you want to cover public sector, private sector, it can also be used there.
All right, thanks.
Linked to the malaria elimination tool, no. I think it's a standalone tool, as I mentioned. Okay. The long-term goal is really to have it integrated into DHIS tool so that the information is pulled out directly from the DHIS tool. So as facility name are concerned and the previous supervision report, data quality issues, so that it can inform during the assessment. Over, thank you.
So Dr. Putnong Bilai, there was a top voted question from you, was also from Jenny. But I see that you've seen that question. I don't know if you'd like to answer live just now. So the question was, how close is Lao to malaria elimination? And what is the API? You're on mute at the moment.
Oh, that's to me?
That's a question regarding Lao. Dr. Bilai.
Oh, sorry.
Sorry,
Dr. Putnalong, you're on mute.
Okay. I think this quite close to eliminations because an APIs in Laos in 2021 around 0.4 per 1,000. Per 100,000. Yeah. However, although the API is really low, however, but then in the southern part of Laos still have the malaria outbreak in small area in the village in a small area. Yeah, that is a really challenge for Lao PDR too.
The second part of the question was whether the use of malaria staff for other infectious diseases was because of lack of funding.
Pardon?
Was using malaria staff for other infectious diseases, is that because of lack of funding?
No. So so the funds so we have from the donor like an common fund from Right to E grant. So we also the implementation in two different area in elimination park and in the burden reductions area too.
Right, thank you. Dr. Rahman, the top voted question for you is from Esitu Mola, and it says, what shall we trust as a benchmark? The different malaria data reporting tiers and hierarchies, like health facilities, district health officers, zonal or regional health departments or ministries of health for reporting malaria data. So what do we trust as the benchmark? If you can see that question.
Can you repeat the question again, sir?
Yeah, it says, what should we trust as benchmark? The different malaria reporting tiers or hierarchies. And then it's got health facilities, district health office, regional health department, or ministry of health for the reporting of malaria data.
Yeah, our benchmark is 100% reporting within time from each service delivery point to the hierarchy, to the upper level. That is our benchmark for reporting. Is it okay, sir?
Great, thank you. Yes.
And it is our performance indicator also to our donor agency, the Global Fund. That 100% facility report within time in each month.
Right, thank you. There's another highly voted question for Dr. Yazame from Can Chow from Impequignon to the Ministry of Health in Vietnam at 1:45 p.m. And it's a 4-part question. It says, where can we find the tool? Is it free access? Was it reviewed and checked? Can it link to online data systems, or do they need to type manually into the Excel file? And what is the cost and NMCP's acceptance?
Great, and this is a good question. I think the tool has been developed as a project tool, but the link can be shared on the MEASURE Malaria project. I think someone actually just shared the link. So it's possible to get the tool and upload it there. So as far as was the tool review and check, not sure what that means. Was it say just like, what has the tool been tested, right? If that's what it's referring to, yes, we went through, a testing process. As you can see, even the implementation process, where now some countries are still testing before they use, some countries were very skeptical. Kenya is one of them, and they have tested and they decided to use it, so they're fully rolling out. And I mean, the good thing is that it derived from an existing tool which have been already validated, which is the DQA tool already used. So in terms of testing, I think it has been validated. The cost to malaria, there was a question on whether it's entered manually. Yes, the information is being entered manually into the tool during the supervision visits. In terms of cost, and can be linked now to DHIS2. So far, that's what we're working on, and that's one of the limitations, but we're working on it and making sure that there's a direct link to DHIS2, so information can be pulled. And even that there's a link for to previous supervision visit. You can upload the information and then use that to inform your current assessment. In terms of cost, yes, the tool itself is not costly. What is costly is the supervision visit or the assessment. So in some country, they're able to have more facility if they have enough money to cover them. But other countries, it's very difficult. So it sort of goes through the supportive supervision, which is actually the idea. It goes quarterly and can be implemented during this time. So far, the country where we are working, we're supporting that process, but I assume this cost can easily be absorbed into costs of supportive supervision for malaria. Thank you.
Thank you. Dr. Rahman, did you have your hand up?
Just adding to Mr. The first panelist, that cost can be minimized by doing sample and strategic planning of this RDQ visit. What we have we have done. We have each month we have sample by lottery method the facility, and thus we minimize the cost for this RDQ tool usefulness. This is my submission, just addition.
Great, thank you for that comment. So there's lots of questions still coming in, and I'm afraid we're going to run out of time, unfortunately. So what we normally do is we compile all the questions from the Q&A and send them out to the presenters, and then you're welcome to type a written answer if you have time to do so. We can then share it with the audience later.
Sure.
So we will have a feedback form for people to fill in. That should pop up on your screen. Be as honest as you can. Let us know what you think of this webinar. Apologies that we ran over time, but we always like to hear everything that the speakers have got to say. So I prefer not to cut people off. And I think I found it really interesting. I learned a lot. And I thought the questions and answers, including some of the answers typed in the chat, also fascinating. So if you can fill in your feedback form, I'd just like to thank all of the participants, all of the speakers. Thank you very much to our audience. I think we had at most about 125 people on the call. And we will have another APMEN Tech Talk from the Surveillance and Response Working Group coming up later in the year. Thank you very much, everybody. The meeting is now closed.